Hi, everyone. Thank you so much for joining us today. We are very excited to be able to discuss the development of Givinostat as a potential treatment for Duchenne Muscular Dystrophy. I'm Kathy Kennett. I'm Senior Vice President of Clinical Care with PPMD, and we're joined by two people from Italfarmaco, who I'll introduce in just 1 minute. Just before we get started, I just wanted everybody to know that you're on mute, and if you have a question, please enter it in the chat box. We'll try to save all of the questions for the end of the webinar, but if questions come up that it looks like would be best to discuss during the webinar, then we'll ask them at that time. And I hope that you enjoy this webinar. Thank you so much again for being here. Paulo Batica is Vice President of R&D of the Givinostat team of Italfarmaco. He's also joined by Sarah, who is a biologist and a nurse and clinical lead for the project. So at this time, I will turn this over to Paulo.
Okay, thanks a lot, Kathy, and thanks obviously to PPMD and to all of you for allowing us to share with you all the information and the knowledge that we have on Givinostat, which is the HDAC inhibitor, which we are developing for the treatment of Duchenne Muscular Dystrophy. And Kathy, can you go to the next one, please? So this is to obviously share with you that I am a full-time employee of Italfarmaco, which is a manufacturer of Givinostat. I want obviously to underline that Givinostat is currently in development, so is not approved for sale in any country, including the United States. And obviously that this presentation is intended for dissemination of scientific information only. If you can go to the next one. So this is a description of what I'm going to be talking about. Firstly, a couple of slides on what Italfarmaco is. Secondly, what we believe is the role of Givinostat in Duchenne Muscular Dystrophy. And then we will go into a bit more details about the preclinical data and the preliminary clinical data that we have published and gathered. And then we'll end up telling you which are the next steps. Next one, please. So Italfarmaco is an Italian privately owned pharmaceutical and fine chemical industry. As you can see from the slide, we are present in different countries, a total of 40 countries around the world, including the US. And if you go to the next one, we are proud actually of having a group of R&D people that are present in 3 different sites in Europe, 2 in Italy and 1 in Spain. And as you can see, our R&D spans through different areas, going from orphan disease to oncology, women health, and generics. If you go to the next one. So now we start talking about Givinostat, which is our front runner for the histone deacetylase inhibitors, and about what we believe is the role of Givinostat in the treatment of Duchenne Muscular Dystrophy. If you go to the next one. So here is a brief description of Givinostat. As I mentioned before, it is a histone deacetylase inhibitor. If we try and simplify this mechanism of action, in essence, the inhibition of HDAC, which I'm going to mention from now on in terms of instead of histone deacetylase, in essence, when you inhibit the HDAC, you allow a increased transcription of some specific genes on the DNA. Givinostat is an oral suspension, so it is taken by mouth by the patients twice a day. And as you can see, because we have actually been studying Givinostat for a long time in different indications, we now have gathered data on more than 500 subjects that have been treated in our clinical trials. And of these 500, 51 are actually children, and of these children, 20 are Duchenne children, that, as you will see also later on, have been now treated for almost 4 years. If you go to the next slide. So what I'm trying to summarize in this cartoon is how, which are the key events in the Duchenne disease that Givinostat can work on. Obviously, we are well aware that the key point here in the disease is the lack of dystrophin. Following the lack of the dystrophin, there are a number of events where we believe Givinostat is acting on. So first of all, because of the lack of dystrophin, there is a repetitive injury of the muscle. That obviously leads to the damage of some of the fibers and what I described there as the fiber necrosis. The usual reaction of the body to events like this one is actually inflammation. And then following inflammation, you would be expecting an increase in satellite cells and the replacement by new muscle fibers. But as we know, with the progression of disease, this does not really occur, but what prevails is actually scarring and fat accumulation. So if you go to the next one, we start talking about where we think that Givinostat works. Well, first of all, which are the data that suggest that Givinostat could work on muscle regeneration? Well, actually, we know that the HDAC2 is under the control of dystrophin and of the dystrophin complex. So when dystrophin is not there, as it is in Duchenne, then the HDAC2 works too much. And this you can see on the cartoon on the right-hand side. And the fact that the HDAC2 works too much means that a number of key factors for muscle regeneration are not being translated. And these are the myogenic factors that you have heard many times, like follistatin, MyoD, you have heard them, as I said, many times. So obviously, if we give a drug like HDAC, like Givinostat, that inhibits the HDAC, then these factors, these myogenic factors, are being translated again. And so by virtue of this activity, we believe that Givinostat can increase the muscle regeneration. If you go to the next slide, we also know, and actually that has been shown by Doles and colleagues some time ago, 3 years ago, that there are a number of inflammatory cytokines, which, as you recall from the previous cartoon, are generated because muscle fibers are being damaged. There are a number of these cytokines that actually keep the satellite controls, if you want, almost frozen, so they cannot really go and replace the muscle fibers which are being damaged. And as you will hear in just a second, we know that actually Givinostat has anti-inflammatory effect. So it is actually reducing the cytokines, and by virtue of that, the satellite cells should restart to evolve into new muscle. If you go to the next one, what we also know, and this is coming also from experiment in other models of disease, is actually that Givinostat can reduce the fibrosis, so the scarring that we see in the muscle of Duchenne. So if we then put all this information together, and if you go to the next one, please. We have just said before that if in Duchenne you have an increase of scarring, an increase of fat accumulation, and a reduction of regeneration. And if you click again, we believe that the addition of Givinostat is actually going to restore this balance towards less fibrosis, less fat accumulation, and an increase in muscle in general. And this is, by the way, something that we have looked at in both in preclinical, in a preclinical study and in a clinical study, which I'm going to describe now. So if you go to the next one, as I said, the first thing that we did was with a group of Lorenzo Puri, a preclinical study in the MDX mouse. If you go to the next one. And this is a summary of the results that we published in 2013. So if you look at the top graph, this is telling you that there is a dose-dependent increase in the area of the muscle fibers. So the administration of Givinostat to the MDX mouse determines an increase in the size of the muscle fibers in the animal. If you then concentrate on the bottom graph, you see that there is a dose-dependent reduction of fibrosis. So with an increase by dose, you reduce in a dose-dependent way the amount of scar that was found in the muscle of the mice. If you go to the next one, if you look at the top right, you see also a dose-dependent reduction in inflammation. And if we put all these histological results together, we then see, looking at the graph at the bottom, that this translates into a better treadmill test for the mice, which, if you think about it, is something similar to the 6-minute walk test in the human being. So if you go to the next one, so obviously these preclinical data were very encouraging, and so what we decided was to conduct a clinical study to understand whether this result could be replicated also in children, in boys with Duchenne muscular dystrophy. So if you click to the next one, and this is a description of the study. So as I said, the key objective of the study was to see whether we could replicate the same histological effects, or the same effect at the muscle level that we had observed in the mouse. And obviously, as usual in this study, to evaluate also the safety and the tolerability of our drug. The study design is described in the top right corner. We enrolled 20 ambulant children. They were 7 to less than 11 years of age when the study started, and they had to be on steroids for at least 6 months, on a stable steroid dose for at least 6 months. And then we initially had a dose escalation to identify which was the best dose to use in these boys. And then we had a 12-month treatment at the end of which we actually collected the muscle biopsy to do our comparison. The inclusion-exclusion criteria, you see what I was saying before. So obviously, because the drug is not particularly related to a genetic defect, we allowed any genetic mutation in the study. As I said, the kids had to be at least 7 and less than 11 years of age at study start, on stable steroids for at least 6 months, and they had to be able to perform at least 250 meters at the 6-minute walk test. And the key analysis was based on the biopsy that was done before any treatment and after 12 months. Next one. Here are just some examples of the biopsies to give you a visual impression of the effect of Givinostat. So at the top you see the baseline value, the baseline biopsies for 4 kids, and at the bottom you see the post-treatment evaluation in those same 4 kids. And you can immediately see that the white parts, which are in essence scars or fat, decrease significantly after treatment. And you also see a more homogeneous pink color, which is in essence a demonstration of increase of muscle. If you go to the next one, obviously one way to look at these results is by imaging analysis. In essence, what one is doing is counting, is measuring the area in the biopsy which is occupied by a certain type of tissue. And if you start from the left-hand side, this is the description, and each bar is one child, and the black bar is actually the mean for the group. You can see that there is an increase in all kids of the percentage of the biopsy which is occupied by muscle. If we go to the total fibrosis, and once again each bar is one child and the black is the mean, you can see that there is almost specular reduction in total fibrosis, so the amount of scar in the biopsy reduces significantly, and the same can be said for total necrosis and for fatty replacement. And as you can see, all these changes were actually highly significant. If you go to the next one, obviously we also looked at the functional test. Let me remind you here that obviously this was a small study. We had only 20 children in the study. But as you can see, the 6-minute walk distance was relatively stable for the 12 months of treatment. And similar can be said for the rise from floor, which was the other time function test that we performed. If you go to the next one, this is a summary of the adverse events that we observed. This is actually very consistent with the general information that we have on Givinostat, where the 2 adverse events which are more frequent, one is diarrhea, which however never led to discontinuation of the drug. And the second one was actually a reduction in platelets, which by dose adjustment we can actually keep under control. If you go to the next one, I think the other thing which is very important about this study is that actually these kids are continuing treatment as we speak. So as you can see, we are now in the 3rd extension of the study, and in 2017 the kids are now in their 4th year of treatment. And of the 20 initial study, we had actually one child that met a stopping criterion at the very beginning of the study in 2013. Then all the others remain in the study except one that in July of 2015 withdrew his consent because he did not want to continue in a clinical trial. If you go to, the one important, thanks. I think one important thing to underline is that obviously now the boys are actually becoming relatively old. At the end of year 3, which is the last collection of data. As you can see, their age is between 10 and almost 14 years, which means that obviously also other parameters become relevant, like the upper limb or the respiratory function. If you go to the next one. So this is a spaghetti plot of the kids' 6-minute walk distance. And as you can see, for most of them, there is a decline, a slow decline in the 6-minute walk distance. We have now 2 kids that actually have lost ambulation, but let me actually have a description of those kids, because the first one is actually a child that had the lowest value also in time to rise. In essence, this child, which you can see starts around 300 6-minute walk test, he was actually unable to perform the time to rise, which, as you know, in the current study is actually an exclusion criteria. And as expected, then in 2 years' time, he then lost the ambulation. The second child who actually lost his ambulation was a child who actually had a fracture of the leg, if I remember correctly, around 6 months into the trial. Then actually the child restarted walking, but then he actually refused to perform the 6-minute walk test because he was afraid of actually falling again. So if you go now to the next slide. This is actually, as I mentioned before, now that the boys actually become older, also other parameters become important. And this is actually a description of the respiratory function. And the 2 parameters which are standard here is one, the PEFp, which is the peak expiratory flow, and is presented as a percentage of predicted. And as you can see, in the 3 years of treatment data that we have, this value is actually increasing. And the other parameter which is important is the vital capacity, the forced vital capacity on the right-hand side, once again as a percentage predicted. And here, in 3 years, as you can see, the average went from 92 to 87. So a loss of approximately less than 5%, which, if you probably remember, you have seen this data other times. The idea from the study of example of Meyer is that the kids at this age actually lose 5%, but every year, not in 3 years. So if we go to the next one, this is then the upper limb, and is the performance of upper limb, which is a scale that is measuring the performance of the upper limb. And you probably recall that there is a total score, but then there are actually some other score which are domain score, looking at the shoulder domain, the mid domain, which is mainly the elbow, and then the distal, which is the hand. And obviously, for the age of the kids, what is important is the shoulder, which is the blue line. And as you can see also here, we have stability for 36 months. If you go to the next one, then going back to the safety and tolerability, and the data at 3 years in essence confirm what I've shown after 1 year, which is that diarrhea and platelet reduction are the 2 most frequent adverse events. On the right-hand side, you also see an insert graph which is showing you that once the dose is being adjusted, then the platelets are maintained within the normal range for the whole duration of the study. So confirming that although the HDAC inhibitors are well known to reduce the platelets, the dose can be adjusted in such a way that the platelets remain within the normal value. If you go to the next one. Okay, let's then finish talking about the next steps. So if you go to the next one. So we are actually in the final stage of getting all the approval for a phase 3 study. This will be a phase 3 study in ambulant boys, age 6 and older. Once again, they have to be on steroids. This is a placebo-controlled study. As you know, there is still a request by the regulatory authorities to compare the results of a new drug to placebo. But we have actually the randomization will be 1 to 2. So for each child that will receive placebo, there will be 2 that will receive Givinostat. Duration of treatment is 18 months. We are conducting the study in the US, Canada, and Europe. And as I said, the FDA has actually cleared the IND, so the regulatory approval has been reached. And we are now in the final process of actually getting the approval from the different IRBs. And what you can see there is that we will shortly hold another webinar that will give you all the details about the study once we have a good number of sites which are open. And in the meantime, as usual, you can go to clinicaltrials.gov to get some initial information. If you go to the next one, this is just to obviously complete, thanking you for your attention, and obviously thanking all the different people that have worked with us so far to gather the results which I've just shown you. And the most important ones are obviously the boys in the study 43 and their family. Thanks a lot.
Thank you so much, Paolo. This is so exciting, and we're thrilled to have you discussing your product today, and we're excited to have Givinostat in our potential pipeline of therapies for these children and families. So could you talk just a little bit more about the effect of Givinostat on platelets and how that's evaluated and what your biggest concerns are and how you change the doses to moderate those effects?
Okay. Yeah, thanks for the question. So we know that actually the HDAC inhibitor reduce platelets. And let me explain how they do that. What we know is that the HDAC inhibitor frees the maturation of the platelets. So what does that mean? Because I think this is important to underline. This means that you see when you have a dose which is too high, you see the reduction in platelets in a relatively short time, usually between 2 and 4 weeks. So obviously that means that in the initial time of the study, we will have a more frequent assessment of the platelets. The other important aspect related to the mechanism of action is that as soon as the dose is stopped, the platelets go back to normal, and usually in the same time, so like 2 to 4 weeks. So what I'm trying to say is that this is an event that we are expecting, but it is an event that we know how to manage at the moment. And the management of this is actually by adjusting the dose to the child. And this is done in essence in 2 ways. One is based on the child weight. So based on the weight that they have, they will receive a certain dose. And then by actually having a frequent assessment of platelets once a week in the initial part of the study, in the first month. with that, we actually have seen also in study 43 that we can avoid the reduction of platelets, which are clinically important. Let me also underline one thing, which I think is important. In all the trials we have conducted so far, we have seen a reduction in platelets, but we have not seen bleeding, which is obviously the part which is very important. Because one thing is a platelet reduction, which is a lab value, and a totally different thing is bleeding, which is what can come out of a pathological reduction of platelets. And as I said, we have not seen that.
Okay, and even with that platelet reduction, the platelet levels still remained within normal limits, correct?
Once the dose is adjusted properly, yes.
Okay, thanks. So if I understand this right, it sounds like this drug has implications for muscle generation as well as anti-inflammatory and anti-fibrotic properties. Would you agree with that assessment?
Absolutely correct, yes.
Okay, good. So given these properties, has there been any discussion of studying this drug in patients younger than 7?
Say it again, sorry. I missed the last part.
Oh, sure. Have you considered studying this drug or the impact of this drug in patients younger than 7?
Yeah, actually, that is in the plan, meaning that, as you probably know, we are actually discussing the pediatric investigational plan with the European authority, which is mandatory. Okay. And part of the big scheme, if you want, is obviously of testing also kids with of a younger age, and then also patients that are non-ambulant anymore.
Okay.
So what we have actually in the plan is actually to take this next study, study 48, to a certain level and a certain interim analysis, and then if the interim analysis is positive, then to trigger the other development.
Okay, that was my next question, was given the stabilization of the pole and the pulmonary function, if you considered studying this drug in the non-ambulant population, but that is in your future plans?
Correct, that is correct.
Okay, great, thanks. Is there a synergy between Givinostat and steroids, do you think, or was there a reason that you chose to trial this drug in a steroid-treated population?
So what we know are a couple of things. First of all, in terms of pharmacokinetic interaction, so if one drug interferes with the other in the way it is absorbed, the answer is no. We have actually tested in the animal and there is no interference. In terms of the pharmacodynamic effect, so to see whether one drug potentiates the effect of the other, this is actually work which is ongoing and will hopefully soon have a result. The approach of actually giving Givinostat on top of steroids is really based on the current standard in terms of not only medical practice but also in terms of clinical trial in this age population.
Okay, thanks. And you did evaluate pulmonary function during your study. Were there any implications for cardiac function or fibrosis, or did you evaluate the heart at all in your study?
So what we did was an echo of the heart at baseline and then every year. We have actually evaluated that obviously in terms of safety to make sure that there was no concern, and the answer is that we have not seen any concern in that regard. Obviously, as the kids are becoming older, then we will be looking at the echo data also in terms of trying to understand whether there is any signal of potential benefit. But that will probably come in the future assessment. I think the kids are relatively young now to see an important effect.
Okay. And given the anti-fibrotic effects of your drug, have you considered using cardiac MRI to evaluate fibrosis?
We have actually considered that. I think for this study, I mean, it's already quite intensive in terms of assessment, so for the next study, study 48. So we decided not to, but it obviously may come in future studies. One thing that is important to keep in mind is in study 48, half of the children will have muscle MRI. So the thigh MRI, and so as you can understand, then the number of assessment can become intensive.
Okay, thanks. So we know that there's an effect on platelets with HDAC inhibitors and Givinostat. Is there any effect on white blood cells with Givinostat? We
have actually seen effect on white blood cell only in much higher doses in oncology patients. So usually what I would say is that for the doses that we use in these patients, and because obviously there are no major effect on blood cells coming from other concomitant therapies, then we should not be expecting any negative effect.
Okay. And it looks like idebenone is an inclusion criteria. Is CoQ10 an exclusion criteria? And what is what's the pharmacokinetics of CoQ10 or idebenone and Givinostat? Why is that an exclusion?
So actually, the idebenone exclusion is that so far, obviously, it is still an exploratory drug. It's not approved yet. So the standard is to exclude any other drug under development, and this is the reason for idebenone. Obviously, given the respiratory effects, which in this specific study is not the primary endpoint, but this is going to be measured, then maybe it's better to actually do not include idebenone. With regards to Q10, that is not exclusionary at the moment, and so that will be allowed.
Okay, so are there any other studies that would be exclusions for children, or would most, if anyone wanted to participate in this trial coming up, do you anticipate a washout period for those other trials, or are you not sure yet?
So what will happen is that we will have a 3 months washout for most of the treatments. One thing which is important is that as obviously the Flazacort is becoming now approved in the U.S., that is allowed. So the kids in the U.S. who are on the Flazacort can actually enter the study. And then for the exon skipping drug and Translarna, we have actually an exclusion for, I think it's still 3 months of washout. So they cannot take it in concomitant, they cannot take it together with Givinostat. They need to be washed out for 3 months, and then they can access the study.
Okay, thanks. Are there muscle biopsies will there be muscle biopsies in your upcoming trial? And it also, my other question was that it looked like the only muscle biopsies were baseline in 12 months. Were any other muscle biopsies done after the 12-month period?
So for the next study, there will be no muscle biopsy. So this is not going to be repeated. For the study 43, no, we did actually do just baseline in 12 months.
Okay, thanks. So you said that in the preclinical data that the muscle fiber the diameter of the muscle fibers actually increased. Did you feel that was due to muscle regeneration, or a decrease in fibrosis? What would you attribute it to?
So at the moment, I can tell you a couple of things. So first of all is that we see an increase of the cross-sectional area of the fibers. So this is clearly an effect on the muscle. It's not, if you want, is independent from the fibrosis. Whether this is due to the fibers becoming larger or new, if you want, muscle fibers attaching to this one, I think both are possible. What we have looked at is also the increase in regenerative fibers and in satellite cells, and we actually see a significant increase in both. So there is both an increase in regenerative fibers and in satellite cells. This is a total satellite cells, while the activated satellite cells remain similar. So this is a bit complicated, but let me explain this a bit better. This means that actually the concern that sometimes people have that with this type of drug you actually exhaust the satellite pool does not seem to be the case with Givinostat, and let me underline that obviously these are data in the human, so these are the human biopsies I'm talking about.
Okay, so you don't feel that there's a risk of satellite cell depletion with the drug in the study?
This is not what we have seen, absolutely.
Okay, excellent. I don't think that I have any other questions, and I think that we have answered most of the other questions. The only other issue were the GI symptoms. Have you found any ways to reduce those GI issues with this drug?
So I can tell you that what we are hearing from the families is that the children actually are having more frequent stools, but usually they are quite able to compensate for that. And in fact, what I said before is that we have not had cases where the drug had to be stopped or where the dose had to be reduced because of the GI side effects.
Okay, thanks. Also, given that at least one of the boys in the study had a fracture, has there been any evaluation of the possible protective effects on bone health with Givinostat, especially in a steroid-using population?
So what I can tell you is based on the tox studies that we have conducted, which, by the way, is in essence we have run all the studies which are needed for registration, except for what is called the carcinogenicity study, which is a long study that usually one does at the end of the development. In all these studies, actually, we have not seen anything suggesting that there might be either a positive or a negative effect on bone. So, by the way, we were trying, the information on the frequency of fracture in Duchenne is not that clear. There are few data actually outside, but we have actually looked in a couple of natural history database, and the frequency that we are observing in the study seems to be very well in line with what is the expected natural history in these children.
Okay. And the steroid doses of the children that were in your study, could it have been any dose regimen? Was it daily? Was it every other day? Or was that important?
So in essence, first of all, let me underline that obviously because the study was conducted in Italy and because nowadays almost the totality of children are on the Flansacort in Italy. All the children were on the Flansacort, and we had actually 50% of them on a daily dose and 50% on an intermittent dose.
Okay, thank you. There's another question about possible sites in the U.S. for your upcoming trial. Have you started to investigate those sites, or is that still under development?
Well, as I was saying before, we are now finalizing the IRB approval and finalizing the opening of the site. So let me postpone this question to the next webinar, where obviously we can be much more detailed.
Okay, I think that's great. I think we've answered all of the questions, and I can't think of anything else to ask. So I'd like to thank Paolo and Sarah for joining us today, and thank you all for joining us in the audience. Thank you for your questions. We hope this has been informative, and we look forward to the next steps with Givinostat in the U.S. So thank you very much.
Well, thank you for allowing us to discuss Givinostat with you. Okay.
Absolutely. Thank you. This ends our webinar.